Hi, everyone. Thanks for joining the talk. My name is Eunice Cho. I'm one of the respirologists working at the general site. And today I'll be presenting on a case of pneumothorax that I encountered in my clinic practice. So I actually took this opportunity to venture a little bit out of my usual respirology theme for the latter part of the presentation. If you guys could mute, yeah, thank you. And for the other part of the presentation, I'll be actually discussing the Ehlers-Danlos syndrome that I encounter for someone with recurrent pneumothorax. So I'll talk briefly on the pneumothorax and its management and move on to the topic of Ehlers-Danlos syndrome today. I'm hoping that this session will be insightful for those of you who may not have clinically encountered EDS patients previously. So I have no conflict of interest to declare. So the goal of this talk today is to learn to differentiate between primary versus secondary pneumothorax. We'll be identifying some of the common and rare causes of pneumothorax, and we'll discuss clinical manifestations of Ehlers-Danlos syndrome and to learn how to diagnose and manage them as a non-specialist. Pneumothorax, it happens when you have actually a collection of air outside the lung, but within the pleural cavity. So you get air accumulating between the parietal and pleural space, and then you get the collapsed lung, and that's the phenomenon we call pneumothorax. So for patients presenting with spontaneous pneumothorax, it can be differentiated into either primary versus secondary spontaneous pneumothorax. Obviously, there are other causes of pneumothorax, such as trauma or iatrogenic, but within the spontaneous pneumothorax, it's either primary or secondary. So for the primary spontaneous pneumothorax, it's referring to those who have no known lung disease, whereas for the secondary spontaneous pneumothorax, we're referring to those people who have pneumothorax with a known underlying lung disease. The recurrence rates are comparable. They're actually quite high. So for the primary spontaneous pneumothorax, it tends to be 17 to 54% within the first year when they initially presented with a pneumothorax, versus 39 to 47% in the secondary spontaneous pneumothorax group. Some of the risk factors for primary spontaneous pneumothorax, so think of a young gentleman who is skinny and who smokes cigarettes. So both for tobacco and cannabis, smoking is associated with increased risk for pneumothorax. And as you can imagine, the higher the factor history, the higher the chance that they will have pneumothorax. Also, if there's any family history of a spontaneous pneumothorax, and a young woman who is pregnant are also at increased risk for developing primary spontaneous pneumothorax. Some of the causes of the secondary pneumothorax are listed here in the order of frequency. So people with airways disease, so COPD, asthma, and infection, most notably TB, necrotizing or cavitary pneumonia, and PJP are also known to cause secondary pneumothorax. ILD patients and those with connective tissue disease, such as rheumatoid, ankylosing spondylitis, dermatomyositis, scleroderma. Again, these diseases are associated with having ILD, CTD-ILD, which puts them at risk for developing pneumothorax. But other entities such as Marfan's and Ehlers-Danlos syndrome, which I'll be discussing a little bit later, are patients with these conditions are also at increased risk for developing pneumothorax. And cancer, sarcoma, lung cancer, as well as thoracic endometriosis. So it's a phenomenon called catamenial pneumothorax. It happens spontaneously, and it could occur recurrently in young women otherwise in the childbearing age. And it tends to be menstrual cycle. So the patient may present with recurrent pneumothorax from the day before up to 72 hours into their menstrual cycle. And they have history of heavy menses, and if they're diagnosed with endometriosis, that's something that you might want to consider on differential diagnosis in young women otherwise. So in terms of pneumothorax, so oftentimes patients present with acute onset of chest pain and shortness of breath, and it tends to occur at rest than with exertion or movement. Diagnosis is made chest X-ray, CT, or ultrasound in some cases. And for treatment options, obviously if it's primary spontaneous pneumothorax, then you could just do conservatively without doing any invasive therapy. So it is just following them with serial chest X-ray to make sure that it gets smaller over time. But other approaches involve needle aspiration, chest tube insertion, as well as chemical and mechanical fluorodesis, and if necessary, involving thoracic surgeon to do VETs and thoracotomy.
793 540 0 and then
If you're the meeting organizer,
Sorry, I'm trying to mute the rest of the.
Fine. No. Are you the organizer?
Yeah, I think so.
You are? Okay,
So
then we're
do I press here?
on.
to the tone, you are now joining the meeting.
Great.
If some of you could mute your microphone, that'd be great.
Please wait.
So obviously we should really resist the temptation to put a chest tube in every single patient presenting with pneumothorax, because it does come with a lot of side effects and discomfort to the patient. So most notably the pain, there are increased risk for pleural infection, bleeding. They could also become hypotensive, and if the air and the fluid gets drained out too quickly, then there are risk of developing flash pulmonary edema. And if their chest tube gets attached to the pleural bag in the wall suction, then they're really stuck in their bed, and they may end up needing to stay in the hospital longer than needed. But chest tube insertion definitely should be considered in patients presenting with a secondary pneumothorax, because they have very low cardiopulmonary reserve. So they may need help with re-expanding their lungs with the aid of the chest tube. So there's actually a study from New England Journal of Medicine that was published in 2020, really supporting that conservative approach for spontaneous pneumothorax is okay. So the goal of the study was to determine if the conservative management of the primary spontaneous pneumothorax was non-inferior to conventional management of primary spontaneous pneumothorax, referring to any kind of invasive measures. So it was a multi-center study that was prospective, randomized, open-label, non-inferiority trial that was conducted in New Zealand and Australia. And they recruited a relatively young patient cohort, so aged 14 to 50, with a unilateral primary spontaneous pneumothorax with a size 32% or greater based on the method that's outlined in the picture. So they randomized the patients presenting with a primary spontaneous pneumothorax and put it into either conservative or intervention arm. And for the patients in the conservative approach, they had a serial chest X-ray at 1 hour from the beginning of when they presented to the hospital, and they repeated another one at the 4-hour mark. And if they were stable and hemologically stable and the patient's pain was tolerable, they were actually discharged home with a clinic follow-up. But in the intervention arm, it was just really up to the physician's discretions that did not involve just looking with a chest X-ray, but whether it's needle aspiration, chest tube, or referral to thoracic surgeon, they had something done. So the primary outcome from the study was that they actually looked at the complete lung re-expansion on chest X-ray at 8 weeks, and it was 98.5% in intervention group versus 94% in the conservative group, with a risk difference of 4.1%. So the conclusion from the primary outcome was that the conservative approach was non-inferior to interventional arm. But when you look at the secondary outcomes, they've had a lot of the secondary outcomes that they looked at, but just a few things to highlight. So the median time to radiological resolution was a lot quicker. So 16 days in intervention group versus 30 days in conservative group. But when you look at the symptom resolution, the difference was really not significant, but slightly quicker in the conservative group compared to the intervention group was noted in the symptom resolution. But when you look at the pneumothorax recurrence rates in the first 12 months, it was actually a lot higher in the intervention group. So 16.8% versus 8.8% in the conservative group. So the patients who had a chest tube or needle aspiration, they were at increased risk of pneumothorax recurrence compared to the conservative group. And also the hospital revisitation rates were higher in the intervention group versus conservative group. So putting it all together, so if we're seeing a patient who presenting with primary spontaneous pneumothorax, otherwise hemologically stable and are reliable enough to come back for follow-up assessments, a conservative approach is actually not bad. The only thing that was good with the intervention arm was that it was a quicker radiological resolution, and they had a higher percentage of the patients who had the full lung expansion at 8 weeks. But otherwise, in terms of the symptom management and the hospital visit rates were a lot better in the conservative arm. So now I'm going to switch the topic of the talk a little bit, and I'll be presenting a case that I saw in my clinic. I saw this young lady that I was asked to see for recurrent pneumothorax. So she was a 39-year-old woman who was referred to me for recurrent pneumothorax. She's actually had about 20 pneumothorax altogether by the time she came to see me in my clinic. Her past medical history was significant for diffuse joint pain, psoriasis, and she has a history of psoriasis and miscarriage at 12 weeks when she was pregnant with her first child. She was obese with BMI greater than 35, and she tells me she had a history of childhood asthma, but she grew out of it and she was no longer on any regular inhaler therapy. The medications that she was on was morphine, Tylenol, and gabapentin. And she was single with no children, but she was an active smoker with about 15 pack-year smoking history, and she worked at a clinic as an administrative assistant. She was born in Canada with no significant TB risk factors. So this is her history of her pneumothorax. So it started back in 2008. She presented to the emergency room with right-sided pneumothorax. She had a needle aspiration done and was discharged home. But about a year later, she presented to the hospital again, this time contralateral side and the left side. She had a pneumothorax. She was admitted at that time and she had a chest tube put in, and she was sent home afterwards after a couple of days. A couple months later, she presented again with the left side pneumothorax. She was admitted, chest tube was put in, and she got sent to thoracic surgery for their opinion because now it was her third time presenting in the hospital. But in the meantime, she kept having recurrent pneumothorax. So she describes it as a sudden onset of chest pain and dyspnea leading to the hospital visits. After she's had the first two, she knew right away when she was having a pneumothorax, and she knew when to go because she said that the pain is quite distinct and that acute onset of shortness of breath, like she knew right away that she was having it. But in between her pneumothorax, she continued to have some residual chest pain, and she complained of having really diffuse joint pain everywhere. And it's been going on for many years. She does not have any chronic cough, phlegm production, or hemoptysis. She said it wasn't related to her menstrual cycle. She had no chest trauma history, and there was no family members with similar issues as her. She knew that smoking itself was a risk factor for recurrent pneumothorax, but she was not able to quit smoking, unfortunately. She told me when she was seeing in my clinic that she was feeling well otherwise, aside from joint pain. And this patient kept calling my office in between her visits for me to prescribe renew her morphine prescription, which I found was very odd. She tells me she was moving from Oakville to Toronto, so she didn't have a family doctor, and the referral was actually made from a walk-in physician who saw her for joint pain, who had to give her a supply of morphine and gabapentin. And I thought it was a little bit strange that a young woman otherwise kept asking me for morphine prescription. When I examined her, she was an obese, mildly obese woman who otherwise looked very comfortable. Her vitals were normal. She had a bit of reduced breath sounds bilaterally, but there was no digital clubbing. Her heart sounds were normal. There was no leg edema. There was no joints that appeared swollen, and there was no significant rash that I could appreciate on my assessment. So this was the extent of my examination. Just to let you know what was done in the background before she came to see me. So she was seen by a thoracic surgery. So she had a right bulectomy done and mechanical pleurodesis. And then she had a left bulectomy done the following year with talc pleurodesis. And she's had multiple recurrent right and left pneumothorax. And she also had a left video thoracic surgery with the red resection. So a lot of things were done to her chest from a thoracic surgery perspective. And this was a pathology that I could get from the Connecting Ontario. So there were some fibrotic changes, but negative for malignancy, some chronic inflammation, and some changes suggestive of respiratory bronchiolitis, likely from her smoking history, and some emphysematous changes. And this was a CT that I organized for her after I saw her in my clinic. So as you can see, this is obviously after she's had multiple thoracic surgery interventions done, but you can see some diffuse bullae and emphysema-like changes in the upper parts of the lung, and some emphysema in the middle part. And this is a coronal view where you can see some upper lobe predominant bullae and emphysema-like changes. But there's no significant like cyst-like changes, no severe advanced fibrosis that you can see on the imaging. I tried to look up for some old imaging to see what it was like before, but the only other CT scan that I could pull up was from February 2018 when she was having an active pneumothorax and was admitted at another hospital. So you can see here that on the left side, she's having a pneumothorax there. And we can see some similar bullae and emphysema-like changes on the right side of the lung. And she has a chest tube put in for her active pneumothorax. So as a respirologist, what did I do? So I organized a PFT for her, given her smoking history and her emphysematous changes. I wanted to see if there was any actual objective compromise in her lung capacity. She's actually failed to attend the appointments that I've arranged for her, so I don't have a PFT to show and share with the group today. I've also ordered some blood work. I found that it was very strange for a young woman to have diffuse joint pain, and as part of the bullous disease workup, I just sent some basic autoimmune panel for her. And I did make a referral back to thoracic surgery just to make sure that there was nothing else that they could do to prevent her from having additional episode of pneumothorax going forth, because she actually lost in touch with her thoracic surgeon as she was moving from one city to another. So these are the results that came back from my initial investigations that are ordered. So her alpha-1 antitrypsin level was normal, but her ANA was positive 1 in 640. Her ENA was also positive with anti-SSA. ANCA was negative otherwise, but she had low complement level and she had mild leukopenia and neutropenia on blood work. So with this blood work results, I sent her to my rheumatology colleague for a comprehensive assessment. So when the rheumatologist saw her, she told her the same thing again, arthralgia in the hands, wrist, and elbow. And she complained of having morning stiffness for more than an hour. And she also said that her pain tended to get worse at the end of the day with excessive use. Ever since she had a thoracic surgery done, she had occasional thoracic spine pain, but she also said that there was no actual swelling of any of the joints, but she complained of having intermittent photosensitive rash and some dizziness at times with orthostatic changes. And she did mention to the rheumatologist about her miscarriage history as well. So when the rheumatologist assessed her in her notes, she also has made a note that there are no tender or swollen joints. But what was interesting in her notes was that she made a note that her thumbs were touching the forearms, her little fingers were extending beyond 9 degrees, and her knees were extending beyond 10 degrees. So putting it all together, the diagnosis that the rheumatology has come up with for this patient was that we're suspecting that she may have lupus, given that her ANA was positive. She's got this photosensitive rash, she's got arthralgia, and she had a history of miscarriage, and some additional blood work was sent from the rheumatologist. But what was most interesting for me was that she's also suspected of having Ehlers-Danlos syndrome, which I wasn't too familiar with. And because the reason that I was suspected in her case was because of her joint hypermobility, arthralgia, and the recurrent pneumothorax history itself. So just to briefly go into a little bit of history about behind Ehlers-Danlos syndrome, people think that it was actually first described by Hippocrates back in 400 BC in his writings called the Airs, Waters, and Places. But officially, it was Dr. Ehlers, who was a Danish physician, when he wrote a case report on a distinct disorder, including lax joints, hyperextensive skin, and bruising. And a couple years later in France, Dr. Danlos wrote a very similar case as Dr. Ehlers, And it was Dr. Parks Weber who decided to come up with the name of this Ehlers-Danlos syndrome, naming after these two physicians who came up with this case reports. So Ehlers-Danlos syndrome is an inherited heterogeneous group of connective tissue disease disorder, noted by hyperextensibility of the skin, tissue fragility marked by the easy bruising, delayed wound healing, and hypermobility of the joints. It can be either autosomal dominant or autosomal recessive, depending on the subtype of this disease. As you can see here, the one on the left side in the A, it's a normal collagen fibrils with a uniform size and spacing. But when you look at the B, it's a patient who has the Ehlers-Danlos syndrome, a particular subtype called the dermatosparaxis. And you can see that there's a dramatic change in the fibril morphology with a severe effects on tensile strength of connective tissue itself. There are actually 13 known types of EDS at this time. I've listed a few here, but the most common one is the hypermobile type. More than 90% of the known EDS cases are actually hypermobile subtype. And classical and vascular are also one of the common types after hypermobile. Initially, the incidence rate was about 1 in 150,000 individuals, but with the more subtypes of the EDS being discovered, the current known incidence is about 1 in 5,000 patients. The slide is directly from the Ehlers-Danlos syndrome website. So just a few subtypes that I just wanted to, for you to see. So depending on the subtype, it can be either autosomal recessive, or if you look at the vascular, it's autosomal dominant. And most of them have a known genetic basis. So it's important to involve the genetics colleagues to see what type of genetic basis they have. But the most common type, as I mentioned, the hypermobile one actually does not have a known genetic basis. So hypermobile EDS is the most common type, and patient can experience hypermobility, skin issues, and other symptoms. The hallmarks of their symptoms are chronic pain and fatigue, dysautonomia, GI issues, TMJ dental problems, spine problems, and mast cell activation disorder. So there's quite a bit of overlap between EDS subtypes and some other connective tissue disease disorder, including the hypermobility spectrum disorder. So some people may not fit into specific categories of EDS based on the diagnostic criteria, but the hypermobility spectrum disorder could also go with the patient if you're suspecting of someone having EDS or who does not meet the diagnostic criteria. Vascular EDS is another subtype that I want to briefly go over. It's because of, it's a rare disorder, but it's known to cause arterial aneurysm, dissection, and ruptures. And they could also have rupture of their bowels, rupture of the uterus. And as a result of this devastating issues, they may have reduced lifespan with a median age a lot shorter than the normal population. So it's very important for the patients that you are suspected of having vascular EDS subtype, have a team of care physicians involved in earlier so that some of this devastating consequences can be prevented. What's interesting as a respirologist for me is that pneumothorax and hemothorax are some of the early manifestations of the vascular EDS, and they're actually considered as one of the minor diagnostic criteria. So vascular EDS is really the only subtype of EDS that has respiratory symptoms in their diagnostic criteria. So EDS is truly a multisystemic disease. So a few things I highlighted earlier, but they also have a lot of GI issues. So the patients with EDS tend to have GERD problems, indigestions, chronic abdominal pain with unknown clear etiology, and they tend to have some food intolerance as well. In pediatric populations who are diagnosed with EDS, apparently there is a high prevalence of this pediatric population with EDS having also the concurrent diagnosis of ADHD as well as autistic spectrum disorder. And across all ages, patients with EDS tend to have high rates of anxiety, depression, and eating disorder. And chronic pain is another big issue for patients with EDS. They complain of excessive pain that is just not well managed in general. And they also have some serious cardiac issues, mitral tricuspid valve prolapse, aortic rule dilatation, and orthostatic complaints are often seen in the patients with EDS. Some of the respiratory manifestations of Ehlers-Danlos syndrome include, as noted in my case, hemothorax, pneumothorax. They may also present just with hemoptysis, cavitary lung disease, bullous emphysema, tracheomalacia, dyspnea, asthma, and sleep apnea. I actually know a colleague of mine who works downtown who has a collection of patients that she has personally diagnosed with EDS based on poorly controlled asthma and some manifestation of tracheomalacia that she saw on the flow volume curve on the PFT. There was something about this patient population that she said that, this asthma patients who also had a lot of chronic pain and joint issues, and she involved some other subspecialists to diagnose them with EDS, and she has a handful of these patients that she follows very closely. These are some of the pictures of the patients who have EDS, so the hyperextensibility of the skin, and then the joints, as you can see in the flexibility of the thumb and the pinky. And I'm going to go over a little bit more in detail how to diagnose someone with hypermobility based on these pictures. These are some of the distinct facial features that you can see in the EDS patients. So they have very prominent eyes, they have thin pinched nose, they have small thin lips, hollow cheeks, and they have small lobeless ears. This distinct features are often described in the vascular EDS subtype of patient population. So how do you make a diagnosis? So EDS it's a clinical diagnosis. So they have a guideline that were updated in 2017. And depending on the subtype, the guideline has a very comprehensive major and minor criteria that you can tick off to see whether the patient meets the criteria for EDS particular subtype. You can assess someone for hypermobility using the Beighton scale, which I'm going to go over in the next 2 slides. But quick screening questions that you can ask in your clinic if you are ever suspecting that someone might have EDS or the spectrum disorder. You ask them about the hypermobility of their joints, easy bruising or scarring, chronic functional gut disorder, asthma history, any food intolerance history, dizziness, headache, or chronic fatigue symptoms. If they score more than 4 of these general questions, then it's possible that they may have some sort of EDS or related spectrum disorder, if it's supported with hypermobility of the joints. So this is the updated guidelines that they have published in 2017. There's a lot of details in this guideline itself. So I just put the title page out there just in case you ever need to make a reference to it. But I want to just briefly go over the Beighton scale that you can use to check for hypermobility of one's joints. So the first one, you check their pinky. So you have them put their arms on the table, and then you bring the pinky up towards the patient. And if it goes beyond the 90 degree, then you give a point on each hand. So you check for both the right and the left, and you give a point. And then you have the patient extend their arm and bring their thumb towards their forearm and check to see if the thumb can touch the arm. And if they do, then you get a point. Again, this is, you check for both sides. So you point for one left and the point for the right arm. And then you have the patient extend their elbow with the palm facing upwards. And if it extends beyond than usual by more than 10 degrees, you give a point on each arm. And you have them stand up, check the knees. And then if it bends backwards more than 10 degrees than usual, then you give them a point on each leg. And lastly, you have them stand up, and you have to ask the patient to bend forward. And if they can touch the floor without bending their knees, then they get a point. But we all know that the joint range of motion decreases with age, and there could be an inverse relationship between the age and the scoring of the system. So the cutoff is usually 5, but for elderly patients, you may use the score 4, or for the pediatric population or younger population, then 6 could be more suitable for that age. So once the patients are diagnosed with the EDS, you really need a multidisciplinary approach to help them dealing with daily issues with their EDS. I think one of the main challenge for them is the chronic fatigue, and some of the symptoms can actually overlap with chronic fatigue syndrome as well. It's also possible that the patients who are diagnosed with chronic fatigue syndrome are misdiagnosed and really have the EDS and vice versa. So some of the things that you want to address them are like sleep disorders, autonomic dysfunction, chronic acute pain, deconditioning, psychological issues, and nutrition deficiency. So you really need a good care team involving physical therapy, psychological therapy, and also the genetic counseling for younger patients who may plan on expanding their families. Exercise physiology is also an important part of their therapy, and then involving the right specialist. So whether it's cardiologist, pain specialist, GI, or respirologist, really involving all these care team members are important in caring for EDS patient population. So we're actually quite fortunate that when I was preparing for this presentation and going into a little bit more into EDS, I came across this clinic at UHN. So they have a Good Hope Ehlers-Danlos syndrome clinic in downtown at the Toronto General Hospital. They have more than 30 people involved in this care team, from physicians to RNs to social workers, PTOT, dietitians, psychologists, and lots of pain specialists. Most of them are anesthesiologists, and some are family doctors coming from the pain training. As well as the medicine subspecialists, cardiologists, GI, respirologist, and neurologist as well. So if you're ever suspecting that someone may have EDS, this is the place that you can refer to. There's a form online that you can fill out to refer them to the clinic. The caveat is there's a very long wait time, so it looks like it takes about 24 months for the patients to be seen initially. So going back to my case, to Ms. P, so after having this working diagnosis of EDS, we did make a referral to genetics, and also made a referral to dermatology because she also has a history of psoriasis, but she also mentioned that her skin, she has a bit of delayed wound healing. So I want a dermatologist to see if there's anything to be biopsied, to see if there's any collagen issues. From my end, I also ordered a sleep study for her. She's obese, and with a working diagnosis of EDS, I thought sleep disorder should also be ruled out. And again, third time I'm arranging PFT for her. I'm hoping that she would attend this time. And I also arranged an echocardiogram just to make sure that there's no other cardiac complications related to EDS in case this is what she has. So just to wrap up my talk, so Ehlers-Danlos syndrome is a heterogeneous genetic disorder that has multisystemic manifestations. And there's a scale called Beighton scale that can be a useful tool to check one's hypermobility. The Ehlers-Danlos Society actually puts in their website that they acknowledge that it's a lot of testing to done for a non-specialist to conduct in their office. So they're actually trying to come up with like one particular test that physicians can do to quickly screen for hypermobility. From a respirologist point of view, pneumothorax can be an early manifestations of vascular EDS subtype, so something for me to be aware of as I see patients who are referred to me for pneumothorax. And early diagnosis and early involvement with the appropriate care team is very important for patients that you're suspected of having EDS. And that's the end of my presentation.